Good night. Welcome, everybody. It's time for Paul and Greg, and we have a few special guests today. The Rachels are back. They've been with us for a long time. They're both in medical school. They're going to take over my practice one day. I'm going to work for them one day. Paul's just a year or two behind, and that's fantastic. And I hope everybody's had a wonderful week. I'm actually almost caught up for the day. Pretty close. It's been a really busy week. We're getting back to normal. We're going to back to seeing patients every day starting next week. And but you can see, if you look at the pictures here, everybody's wearing a mask, and some really intriguing masks there. Paul, where's your mask?
I actually have a good 3 or 4 just waiting around in my room. My mom is actually in a room sewing some of her own masks right now.
Wow.
She's getting creative with those. So maybe I could show those by the end of the night if she has them done.
Okay. On my computer, there's a little gray thing. Is that on your computer too as well?
Yeah, I think, Rachel, if you have any menus open, you might need to.
Do I?
Oh, yeah, that's good.
Okay.
Oh, that's back.
Well, before we get started, I wanted to see, does anybody have any questions or thoughts or comments? I really enjoyed last week's talk about 30 days to a healthier you. What I'm thinking is that we want at the end is that people have any questions, please call, talk, interrupt us along the way. You know me, I interrupt. So if you have any questions, just let Paul know, and we'll unmute you, or just talk away. But this has been a fascinating week. In Ontario, things are opening up. How's things in Vancouver then, Rachel?
Pretty good. It was pretty rainy today. There's actually a lot of traffic on the road nowadays. I was surprised when I had to go out today.
Are people out and about more in Vancouver?
Not on the streets per se, but like on the roads, there are a lot of cars.
Yeah. So one of the things is that remember, Paul, I said I was supposed to do 200 kilometers of bike riding this week.
Yeah.
Well, what happened on Saturday went on, Sunday went on. I went out for about 7 hours on Sunday, and I did about 90 kilometers that one day. So I did 150 kilometers just on the last weekend, but I only did another 10 more this morning, and I put myself back on the scale, and I'm down to 172 pounds this week. So
nice, that's progress. Okay.
So at least I'm not up. I'm fighting away, and let's see the next picture we have here. So wear your mask, keep your social distances. This is actually in the clinic, and if you look in the middle, there's Carrie, my lovely wife, was kind enough to make a whole wheat pizza and a whole wheat crust. As you know, I had some friends that bought a huge bag of flour. We have enough of whole wheat flour to feed half the world, and so that was great. And there we have our healthy lunch. You can see there's no cheese on that pizza. And then Grant Crossing is in Brantford, these bike paths, and that's where I met a couple people. We did some biking. Went to Paris. We went all over the place, and one of the guys I play squash with, wants to go for a 5:30 bike ride tomorrow morning. He wants to see a sunrise, and so we're getting up. He's going to meet at my place at 5:30. We're going for a bike ride. So anybody wants to go biking tomorrow, we're meeting at my place at 5:30. There's a good cardiology meeting tomorrow starting at 9 o'clock. So I figure we have a few hours. And one of the things that would happen this week is that the specials at Tim Hortons, the 2 for $1 or 2 for $5 sandwiches they're no longer there. So, but I got a couple before the last few days, and the bacon, my dogs love them all the time, and so my coffee is basically extra large coffee with large coffee, and none of that sugar or cream. And so I'm really working hard, and everyone in our clinic is working hard as well. What's our next slide, Paul? So we eat healthy, and do you want to share that with us?
Reduction. So how much weight have you lost? I've lost altogether 30 pounds.
How'd you do that?
So I was on two different medications. First, I started with Saxendra, and I've lost about 20 pounds of Saxendra. And then Dr. Kearney, when we were talking on one of the visits, I told him that I plateau on a Saxendra. My weight was stable at that point. He recommended switching to Ozempic, and I lost additional 10 pounds on Ozempic. So I went down from 183 to 153. Actually, I was less about 2 weeks ago before I was less before COVID-19 started. But, you know, I've been doing a lot of baking and cooking during those extra times. But 153 is fantastic. This is the best weight I've been in probably last 15 years. I have much more energy. I feel much stronger. I feel much more happier about myself.
So when you lose weight, good things happen. And for many of us, it's a challenge. So these medications affect hormones that we use for diabetes, gut hormones, but they also affect the brain, decrease appetite. Well, they're not for everybody. In your case, your response has been dramatic. If you get 10 to 20 pounds, that's fantastic. The problem is they're expensive and not covered by too many insurance plans. So how about your situation? How much?
I'm paying at this point $153 or $156. I purchase at Costco. I received information to a drug card through Dr. Korniev, and I did ask for the drug card, and that saves me about $50 a month. So instead of paying $220, I'm paying $153 or $156. I don't remember exactly.
So
but it's really worth it.
Yeah, so it is expensive.
It is expensive.
And it's approved in Canada for diabetes at this stage.
Yes.
And I think it does. I've tried it myself in the past, and it helps curb my appetite. Nothing curbs my appetite totally. It still doesn't replace the hard work that's involved with diet and exercise. So for some people, it certainly can help. And
Yes.
Thank you very much for sharing that.
Oh, you're very welcome. Thank you, and good luck to everybody.
Well, wonderful story. You know, it's we have to take our wins when we get them. And to me, you want to combine the best of lifestyle changes. And she's worked very hard at this. And the medication did help her as well. So I'm not saying this is for everybody, but I just want to show you some examples. I'm plugging away. My nighttime eating is still a problem, but it's I'm getting more activity with this. So it's really success. So one of the things that what we learned is that your weight affects so many organ systems, from your cholesterol to your heart, now to COVID-19. Everybody should be working hard. And one of the things I learned this week, which I was kind of disappointed to find out, is that in Ontario, alcohol consumption has gone up by 30 to 40% during the COVID-19 pandemic. And alcohol is not a health food. It's rich in calories. I'm thinking is that we call this the war against COVID-19. And if you're on the battlefield, you want to stack the odds in your favor. So I'm not too happy to hear those numbers there. I do know that bike sales have gone up dramatically in Ontario. I'm not so sure about the fact that pubs and pool sales have gone up dramatically. I like the fact that bikes are going up and gardens are gone up too as well. You can't get seeds and things. So there's some good things, and we'll keep fighting. And today we're going to spend a little bit of time talking about cholesterol, what it means to you. And I'm really looking forward to our special guests, the Rachels, and they have lots of magic together. They've done a lot to help people, and let's hear what you have to say. Well, welcome back. Thank you for coming. Thank you so much for being here.
Well, thank you for the introduction, Dr. Kearney. We're glad to be here as well, continuing to be involved in the clinic. So today we are going to talk to you about living with high cholesterol and how you can make that high cholesterol a bit lower. So we have a bit of an agenda for today. One is we'll talk about the basics. So what is cholesterol and why is it important? What does it have to do with heart disease? Why does Dr. Kearney care about it? And then we'll go a little bit into what causes high cholesterol. and how you can lower it with something called the portfolio diet. There are also medications, of course, some of you may be familiar with for cholesterol. Dr. Kearney is a big fan of cholesterol medications, as most of you would know. So we'll talk a little bit about how these medications work, some of the questions that we've gotten, the side effects, the worries that patients come in with. We'll all talk about that. And then we'll leave some time for questions and discussions at the end. If you do have any questions, feel free to type them in the chat. I'm thinking Paul will monitor that for me, and he'll stop me if he thinks it's something that we can answer during the talk. Okay, so to start off, cholesterol is a very, very important molecule in the body. It's so important that every single cell in your body can make their own cholesterol, except for red blood cells, because they lack the machinery to do so. But there's a big difference to its reputation depending on where the cholesterol is. So there are two main places that cholesterol can be in. One is in your blood vessels, one is outside of your blood vessels. So when it is outside of your blood vessels, when it's in the cells and the cell membranes, it's good because it's very essential for a number of bodily processes that are needed for us to survive. So one of them is hormones. Cholesterol is part of very important hormones like your sex hormones, like your thyroid hormones, and they're needed for us to function properly. It is also very important for your brain function and for your nerves to function properly. It is also the base material to make vitamin D. So this cholesterol in your skin cells, when they are exposed to sunlight, the cell is able to use that cholesterol and turn them into vitamin D. And we all know vitamin D, along with calcium, is very important for bone health. So indirectly, cholesterol is very important in maintaining your bone health. And again, vitamin D is very important for your immune system. So again, cholesterol is indirectly related to a good immune function. This is especially important in the COVID-19 situation right now. And last but not least, one of the major functions of cholesterol is to make up bile. Bile is a component of your digestive system, and it helps you digest the fats that you eat. So these are all the good things about cholesterol. And this is when cholesterol is in a place that it's supposed to be, not inside your blood vessels. But when it's in your blood vessels, something different happens. So when cholesterol builds up in your blood vessels, in your blood, it causes blockages in those vessels. And when you have blockages, as you see in this image here, the blood vessels is narrowed, and it's very hard to get blood across. So it'll cause a lack of blood supply to various parts of your body. It could be in your brain, where it leads to a stroke. Could be in your heart, leading to a heart attack. It could be in your limbs, leading to peripheral vascular disease, or in other organs. So this is the main reason why doctors, and especially cardiologists, want to reduce your cholesterol, why they're so interested in cholesterol, because of the fact that cholesterol causes cardiovascular disease. If you want to learn more about how this process occurs in your body, we are having an atherosclerosis webinar soon that you can come to, and we'll talk to you more about the in-depth mechanisms. Okay, so this is an example on the more extreme side, but just so that you can see what happens if someone's cholesterol is really, really, really high. This is a 4-year-old boy, and he has a genetic disease. The genetic disease is called homozygous familial hypercholesterolemia. So basically, something is wrong with his genes that causes him to have very, very high cholesterol levels in his blood. His cholesterol was 20 millimoles per liter, which is 10 times higher than what we'd like your cholesterol to be. And medications was unfortunately not effective in treating his cholesterol. So he did not respond to the statin therapies that are usually used in patients with high cholesterol. And unfortunately, he died suddenly at the age of 4. That's a very, very young age to die of. And the reason that he passed away was because the main artery of his heart, what we call the left coronary artery, was 98% blocked off by cholesterol plaque. And this is what his artery looked like. There's barely any opening that you can see. If you can see my mouse, you can see I'm pointing at this tiny sliver of white in all these blockages. The red circle tells you what the artery should look like. The whole red circle should be open and patent and wide so blood can flow through properly. But his whole blood vessel was blocked off, basically. And so basically he died of a heart attack at the age of 4 because his cholesterol was 10 times higher than normal.
So this brings up a really important point. When I hear people say that cholesterol has nothing to do with heart disease, tell that to that 4-year-old. The earliest report of heart attack in this genetic abnormality is the age of 2. Now, there's probably 30 people or 30 to 50 people in Canada with this specific genetic disorder, where you have no LDL receptors, which we're going to talk about in a little bit. So this is what we learned from genetic studies. So I wish this to nobody, but to say that cholesterol is not associated with heart disease, here is a great example to show you cholesterol is very important. So we talked about cholesterol is very important for different hormone productions in different parts of your body, but if it's in the wrong place or too high, it's a killing disease process. So this is something that I want people to think about. Next time when your friends or your next door neighbor or anybody says that cholesterol has nothing to do with heart disease, it has a lot to do with heart disease. Next slide, please. Thanks.
Yes. So there's a scientist on PME, and he gave us some predictions based on the evidence that he looked at of your level of cholesterol and your age of heart attack. So this is what he is proposing. So he's saying that if you have a genetic disease that causes your cholesterol to be 15 to 30 millimoles per liter since you're born, you are probably going to have a heart attack between 3 to 6 years old. So that's very early. If you have a less severe genetic disease called heterozygous familial hypercholesterolemia, which is a very common genetic disease, your LDL cholesterol when you're born would be around 4 to 10 millimoles per liter. And if you leave that untreated, you are probably going to have a heart attack between 30 and 60 years old. For people with normal genes, so no genes that will change your cholesterol, we usually have an LDL cholesterol of 2 to 3 millimoles. And the average age of having a heart attack for someone with this cholesterol level is 80 to 100 years old, which is around the end of life, at least in earlier years for many people. Now, there is also a very interesting genetic mutation that causes you to have very, very low cholesterol. So it's a beneficial mutation in terms of heart disease, and it causes you to have 0.5 to 1.5 millimoles of cholesterol. And that can actually increase, as he predicts, your heart attack age. So you won't get a heart attack, hopefully, until you're 105 or to 125 years old.
So this is actually some modeling based on just cholesterol, based on scientific data. So just to realize, when you're born with an LDL cholesterol, lousy cholesterol between 0.7 and 1.5 millimoles per liter. The average Canadian develops a cholesterol of total cholesterol 5, LDLs between 2 and 3.5 range over your lifetime. Cholesterol tends to rise as we get older, as we gain weight, as our diets change. So in countries that are plant-based eaters, they don't see the rise in cholesterol as we see in North America. And having an average cholesterol will give you a very high probability having a heart attack or stroke. I remind ourselves is that what I always say is that cholesterol you're born with, if you're normal, with an LDL between 0.7 1.7 to 1.5 should be the cholesterol you die with in ideal circumstances. So it just tells us lifelong exposure to lousy cholesterol in the bloodstream is a bad thing. The other interesting observation is that you point out that every cell in your body can make its own cholesterol, except for mature red cells. So that means is that I don't need any LDL cholesterol in my bloodstream to survive. I need my other cells in my body to make its own cholesterol. So this is actually very important to realize that. So thank you for sharing that, Rachel.
No worries. Okay, so here's an early take-home message, and we'll go through the message together. There is a type and place for everything. First of all, place. The bad place is in the blood vessels, and the good place is outside of the blood vessels. So place is blood. Type, L stands for lousy. Lousy cholesterol is bad. H stands for healthy, and healthy cholesterol is good. So we're targeting your LDL cholesterol. And the amount. So based on a lot of scientific research over the past years, we've gotten to know that lousy cholesterol is always lousy at any amount, period. So your end message is you need to get your blood LDL as low as possible. If you take anything away from this meeting today, is that your blood LDL should be as low as possible. And that's specifically for the LDL. We're going to talk a little bit more about the other healthy cholesterol in just a moment. So remember, the place, type, and amount of cholesterol matters in what we're treating for. And how is this cholesterol measured? How do we know you are at target for your cholesterol levels? It's measured through a simple blood test that Dr. Kearney will give you. And there are 4 numbers that we look at. So one is called the total cholesterol. The total cholesterol is a combination of all the good and all the bad cholesterols. The second one is the LDL, the lousy cholesterol. Its scientific name is low density lipoprotein. And this lousy cholesterol is actually calculated using another measured value, and we'll look at that very soon. The third one is called high density lipoprotein. That's a healthy cholesterol. And that actually helps remove your lousy cholesterol from your blood. You want this cholesterol to be at a high level. Last but not least, we have something called triglycerides, which you may have heard of. This is another type of fat in the body. It's the main component of dietary fat, which means it is very responsive to dietary changes. If you have a very high triglyceride, if you lose weight, if you stop drinking alcohol, if you eat less fatty foods, your triglyceride can be relatively easily lowered with just lifestyle changes. Compare that to cholesterol. It's very hard to change cholesterol significantly just with lifestyle changes, and you'll see why in a bit later in the next slide. Which is why statins are so important in cardiology and in preventative cardiology, because it's very hard to change your cholesterol otherwise. So triglyceride is what is used to actually calculate your lousy cholesterol. So in patients who have very, very high triglycerides, the lab cannot actually calculate your lousy cholesterol. So you won't get a value on your lab report for your lousy cholesterol. That does not mean you don't have lousy cholesterol. It just means that we don't know what it is. It could be very high, but we won't know until you're able to lower your triglyceride values.
All right, so like the other Rachel mentioned, when it comes to LDL, lower is always better. An LDL of 0 is better than an LDL of 2. But let's say you're looking at your blood work results and you just want to see like, oh, at what level should I be in the clear? So these are some guidelines from the European Society of Cardiology. I would think that most patients who are seeing Dr. Kearney would be at the moderate to high risk level. So when you look at your lab work results and you're looking at your LDL cholesterol specifically, some numbers that you want to be at is less than around 2.6 millimoles per liter or around less than 1.8. So when we're trying to categorize what classifies someone as moderate risk, high risk, what are some things that go into that? Well, there's a lot of different components that put someone at risk of developing cardiovascular disease. So there's age, gender, if you're a smoker, if you have high blood pressure, So all of those go into consideration. But this is just a good guideline. Maybe write down these numbers so that you can keep them in track. And the next time you get your blood work results, you can compare them to that.
So one of the things that, if you go back that one slide, is that traditionally we've been saying we want the LDL or lousy cholesterol less than 2. That was valid a couple of years ago. We now have data that lower is always better, and so we have different definitions. If you don't smoke, you're looking after yourself, you don't have heart disease, then you can let your LDL cholesterol drift up to much higher values. On the other hand, the very high-risk people are people who have more than one heart attack. I had a bypass at the age of 50, then I had an angioplasty at the age of 55. I have diabetes. I'm thinking about stopping smoking. You are extremely very high risk. And right now is a recommendation is to get the LDL cholesterol at least less than 1.5 or less than 1.4, even less than 1. So in individuals who have more than one heart attack, more cardiovascular event, you've had a stroke, you have blocked arteries in your legs, you have vascular disease in more than one territory, I would want my LDL cholesterol well less than 1. And so that's what I would be aiming for many of you. I'm very pleased that in some people, I'm trying to get LDL cholesterol close to 0. And that's a very select group of people, and that's something you have to talk about, whether that's right for you. On the other hand, you're 80 years of age and never had anything bad happen to you at this stage in life. You can let the LDL cholesterol rise higher, but I want to stack the odds in your favor to make that happen. So the Americans have used 1.8. Canada is going to come up with some guidelines sometime this year, but the European guidelines that came out in 2019 are probably the best guidelines I've written so far. So if anybody wants to look into scientific data, look at where science comes from. So what I'm saying is that you can Google anything, but Google sites that are really tell you about science. And what we learned about, false news, you can hear certain politicians are very preachy, and I don't have to name names, but science is science, and I'm learning all the time, and everything's a moving target right now. So this is a very exciting time. We can lower the risk of having a heart attack or stroke by 60% quite easily if we want to. I'll repeat that. You and I can lower your risk of having a heart attack or stroke by 60% if we do certain things. Go ahead, Rachel.
Okay. All right. So this is just a slide hoping to tell you where that cholesterol comes from in your body. So when I say that cholesterol is very hard to change with lifestyle changes, it's because most of your cholesterol doesn't depend on what you eat. So around 80% of your cholesterol is actually made in your body by your liver, by your intestines, and only 20% of cholesterol in your body comes from what you eat. And that is majorly animal products. So things like meat, cheese, fast foods, fried foods especially have a lot of cholesterol. These things increase your cholesterol by around 20% or contribute about 20% to the cholesterol in your body. So this is the reason why statins are so important, because statins target that 80%, not the 20%. There are medications that target the 20%, which we will talk about a bit later as well. But statins is the mainstay because it targets the 80%, and that's why it's so effective.
Right. So some of the things that contribute to high cholesterol and the risk of developing heart disease. So we mentioned the diet part, specifically the fast foods, the processed foods. Right now we know that trans fats are bad, so stay away from those as much as you can. Weight. So weight is a huge problem in North America right now. Just being overweight and obesity is going up at really high exceeding levels. And that all just contributes to the atherosclerotic plaque buildup in your body, high cholesterol levels in your blood, and increased risk of cardiovascular disease. Inactivity. So lack of exercise is also a major contributor. If you remember from what Rachel said, there's two types of cholesterol. So there's healthy cholesterol, and then there's a lousy cholesterol. Exercise can actually help you increase your healthy cholesterol a little bit, which actually helps decrease the bad cholesterol in your blood. So increasing your exercise can help decrease your risk of having a high bad cholesterol and developing heart disease. We talked about the genetics. Some people are just genetically predisposed to having high cholesterol. Smoking puts a lot of stress on your arteries, causes these little micro tears, and allows more plaque to build up in your arteries, increasing your risk of heart disease. Diabetes and just having increased sugar in your blood also does the same thing. And age, there's a reason why young people don't die of heart attacks. As you get older, your body's clearance of cholesterol, your weight, your activity all contribute to just being at a higher risk of developing high cholesterol and heart disease. So all these multitude of factors kind of come into play, and we just need to be mindful that it's not just one single thing, and we kind of need to work really hard all these different areas to try to stay as healthy as we can.
So I'm going to stop aging at this stage.
So this is a question that a lot of people have. What kind of diet should I eat if I have high cholesterol? It's kind of a controversial area. What we want to get through is it's not just one size fits all. Right now, it kind of seems like the main issue is the majority of North Americans are overweight. When it comes to lowering your cholesterol and reducing your risk of heart disease, it's not really what you eat, but how much you're eating is probably the first step that we can all take. Best practice is to stick to a diet that's sustainable and will allow you to lose weight. So this picture here, classic plate of steak and potatoes, looks pretty delicious to me, and it seems like a very just traditional dinner. Doesn't look like such large proportions, but if you actually calculate that, that's probably pretty high calorie, lots of red meat, high carb, and one thing that I see is missing is some vegetables. So if you're like a meat and potatoes person, probably very unlikely that you're going to be able to lose weight and lower your cholesterol. If you're really, really set on having that meat and potatoes, what we recommend is just cutting that portion in half and replacing it with some sort of green leafy vegetable like we did here.
Okay, so this is what's called the portfolio diet. It's invented by Dr. Jenkins at the University of Toronto. And we wanted to stress that a diet for lowering cholesterol is more than avoiding certain types of foods. Some people say, oh, don't eat meat, or don't eat eggs, or don't drink alcohol. It's good to avoid what can increase your cholesterol, but it's also important to incorporate a combination of foods that will lower cholesterol. And this is the portfolio diet. It's a diet portfolio of the foods that you should be incorporating into what you eat on a daily basis. And so it's made up of four main components. One is vegetable or soy proteins. The second is plant sterols. Third is nuts. And fourth is soluble fiber. And these are some common foods that you see every day. It's just a matter of incorporating it so that you're eating some every day and you're meeting the recommended amounts. So we had the number of grams for each component written here. So for vegetables and soy proteins, you hear the name soy, you probably think of soy milk, tofu, soybeans. Lentils and beans are also very high in vegetable proteins. Plant sterols, not many of you may have heard about it. It is not as easy to get from natural foods. It's mostly going to come from plant sterol fortified foods, things that are in liquid oils, in juices, in yogurts. You'll have a little label that says plant sterol fortified. It's very hard to get 2 grams of plant sterols just by eating vegetables, even if you eat a lot of vegetables. For nuts, all the nuts that we're familiar with, not just these, but there's walnuts, pistachios, almonds. We say nuts, and peanut is not technically a nut, but it is included in the portfolio diet. So yes, you can eat peanuts. It's considered a nut at this point in time. Soluble fibers are present in a lot of different foods. You have avocados, you have oats, Brussels sprouts. Not very many people like it, but it is very good for you, like your mom tells you. You have sweet potatoes and you have oranges, as well as everything else I just talked about. So all the vegetable proteins will have soluble fiber in them. The nuts have some soluble fiber in them, as well as just fruits and vegetables in general has soluble fiber. So if you are able to get enough vegetable and soy proteins as well as nuts in your diet, you should have no trouble reaching that soluble fiber target. So
Now,
this is yeah.
when you look at this diet, to some people it's daunting, but you know what? It's not so bad. There's some changes. I see Chad's on there. Chad and I have completed the Forks Over Knives cooking course. Or I'm sorry, Chad, you completed it with a little bit of support from myself. And I really enjoyed the time learning how to use a chef's knife, how to cook without oil. And when we were in clinic, the Rachels would cook with beans and lentils, and I've really changed so much. Actually, I love Brussels sprouts. I love sweet potatoes. I know Paul loves sweet potatoes more than I do. But there's a way of incorporating, and Chad, you make a pretty mean pizza, but you know what? I think my wife can challenge you for that. Yeah.
Challenge.
And so one of the things that we're going to do is that we're going to actually open up some sessions on, we'll call it oil-free cooking, and how to incorporate. Now, you can go gung-ho and do this 7 days a week, or you can do one meal at a time or 1 day a week. So this is actually really neat. I've learned whole new tastes out there, and so again, Rachel tells us about meat and potatoes. If you want to be a meat and potato guy or lady, you're going to die early in life. I'm sorry. There's just it's just not a health food. But if you're willing to explore and how to make really good pizza, how to add oatmeal parfait. You can make a cream sauce with cashews. I'm not saying I still am a fan of tomatoes, so please take the time to explore a little bit and try a few things, and we'll help you with that. And it's wonderful. I still remember the time when Rachel brought in a meal of 4 grams of pure EPA or EPA with salmon, and it was really good. And so everything is doable. But keep trying and keep getting better. I still have a lot to learn. And you guys have taught me a lot and supported me, and I'll support anybody who wants to make some of these changes. You have to go at your pace, but get the pace a little bit faster for most of us.
Mm-hmm.
Okay. I'm going to interrupt for 1 second as well. 2 things. One is a question for YouTube for you, Rachel. Are these amounts recommended daily that are on the screen here?
Yes, they're recommended daily.
Okay, wonderful. And the second is, after you finish talking about the portfolio diet, Chad was hoping to get a few words in as well about his diet experiences too. So I guess whenever you wrap up this section, we just hand the floor to Chad for a couple minutes.
Yes, for sure. One thing I just wanted to emphasize is, as the other Rachel said before, the important thing about a diet, quote unquote, is not to focus on specific foods to put in your diet, or specific foods you have to eat, specific foods you can't eat at all costs. It's more so pick something that you can sustain for a long period of time, because maintaining the classic portfolio diet, sure, it can help decrease your cholesterol, but only decreasing your cholesterol for 6 months it doesn't really do any benefit for you in the long term, because you still have those 20-30 years of unhealthy eating, of high cholesterol that you are not able to maintain because you can't stick to the diet. It's not meant for you. So these are just guidelines. They're references of things that you can incorporate, things that can help lower your cholesterol. And you pick and choose what you like. You pick and choose what works for you. There's no one-size-fit-all diet. It doesn't exist. One thing about the portfolio diet specifically is that it is meant for lowering cholesterol. It was researched with lowering cholesterol in mind, and it can reduce your LDL, your lousy cholesterol, by 20 to 30%. That is equivalent to a low-intensity statin, and you'll learn about what a low-intensity statin is in a few slides. But adhering to a portfolio diet, or adhering to foods that can help lower your cholesterol, as well as avoiding foods that increase your cholesterol, can be as effective as a low-intensity medication. So you can get off maybe your low-intensity statin if you're able to do it with a portfolio diet. And Chad, would you like to share your experiences?
You have to unmute yourself, Chad.
I just did. Okay. So, and to both Rachel's excellent seminar and where you've taken it in that, but I have to, I'm going to argue a little bit because I really believe you can make a difference if you stay on a strict whole food plant-based diet. And I've clinically made a difference with the clinical studies of my own by getting blood work done when I went on a whole food plant-based diet with no fats or anything just like that. For 1 month, I was able to reduce my level down by half. Then I reduced all oils, and that made a difference. And then Dr. Kernu encouraged me also to go on the statin, which then my cholesterol level reduced another amount. So I think there's a combination of everything. Yes, getting more education with my visits with Dr. Kernu on the statin. It is really important to add that in our lifestyle, anybody who's being affected with cardiovascular disease. But in the past, I was told after my 2 heart attacks and 4 stents that there was nothing that I could do because I was genetically predisposed by it because of my family traits of my family. And everybody dying by the time they were 56. Well, I'm 55 years old now. I changed. I saw what happened with my family. I changed to whole food plant-based eating. I feel terrific. And to anyone out there, if you can just do it, try and challenge yourself and do it for a period of time. I understand that we all grew up in our age group with all kinds of different meats and about the protein. You have to have your meats, but doing more research if you can on the internet and watching different videos like Forks Over Knives, or there's a few other videos out there. The world's healthiest or strongest man out there is a vegan, and I swear by that type of diet, you can make a big reduction. You can live a lot longer going plant-based, whole food, and then adding in your statin as well. Mm-hmm. So, yeah, I made a difference even though I was genetically predisposed to cholesterol.
For sure. I completely agree with you, Chad, that a whole food plant-based diet can make a big difference in someone's cholesterol. I think I remember it's not very common that this happens because it's very hard to do for most patients. But I do remember Dr. Kearney had one patient. She was a young patient, had genetically high cholesterol, but she wanted to change her lifestyle. And I think she was one of the only patients that I know of in Dr. Kearney's practice that was able to do that. She went completely vegan, completely plant-based, and her cholesterol did go down to the same amount as it would have if she was taking a statin. The only thing is that it is a very hard transition for most people. If you are able to do it, it has so much benefits. But you have to be able to maintain it, and that's usually the hard part. If you tell someone to do whole food plant-based for a week, I'm sure most people could do it. If you tell them to do it for 6 months or a year, maybe, I don't know, 10, 20% could do it. If you tell them to maintain that for even longer, I'm not sure how many people are able to maintain that, are able to maintain the benefits of a plant-based diet. But definitely, as Chad said, if you are able to transition to a whole food plant-based diet, because as I said, anything that's processed, that's fried, has lots of cholesterol, and most of the cholesterol comes from animal products. So if you avoid those two things, then yes, you can reduce your cholesterol by a significant amount. Even the portfolio diet is a plant-based diet. You don't see any animal products in there except for the yogurt with the fortified plant sterols. But the majority of the portfolio diet is plant-based as well. So if you want a general target or a general direction of where to work towards, whole food plant-based is the direction to go. I would say so. Rachel, do you have anything to add?
I completely agree. And Chad, I really commend you on all your success with your diet. Kind of similar to Rachel, I can think of a particular patient that I saw at Dr. Kearney's clinic. He was a middle-aged man, started cholesterol level around 6, didn't want to go on medications, lost around 30-ish pounds with intermittent fasting. I think he was eating around 1 meal a day, switched to a largely plant-based diet. I think he ate meat products around once a week, and his cholesterol went down to 3. But just from the sound of that, that's a really drastic change that he made in his diet and his lifestyle. And so the times where I have seen those lifestyle changes impact your cholesterol a lot, it has been really drastic and severe like that. It's not sustainable for everyone. I personally would not be able to do it. I don't have that superstar motivation like Chad and the patient that Rachel was talking about, or this patient that I have in mind. And sometimes I just need a little bit extra help. So for me personally, I find it best to make some small changes here and there. I'll eat plant-based a couple days a week, try to get an exercise a couple days a week. And if it needs to be like later on, I need a little bit of extra boost from a statin, I will be open to taking that too, because I am just not confident in my ability to adhere to a super strict diet all the time. But for those of you who can, completely commend you guys on that.
Okay, can I, and thank you very much, both Rachels, for your feedback, and that's very valuable, and it is. Out of the 2021 participants we've had in this seminar here, you're coming on board because you want to make a difference. The thing is, you got a soul search. Do you want to continue to live a nice, healthy life where you can breathe properly, you can exercise, you just feel better overall? So it's up to every single individual on what they're going to end up doing. So the old saying is, you can lead a horse to the water, but you can't make the horse drink the water, right? So Dr. Canoe, my God, you're the best cardiologist in Canada. I am so impressed that you go beyond the call of duty and spend so much time trying to encourage your patients to be able to live longer. So amazing. And your group of people, as Paul and both Rachel's and everybody else you have on board. But yes, you can try and educate the people, but we got to take it on board ourselves as patients and go, well, how much do you enjoy life? Do you want to die at the age of whatever, in the mid 50s, 60s, 70s, or you want to go on to your 80s or your 90s, right? So it is, you can give as much information as you can, but everybody who's on this seminar right now, I've made a difference, and you can all do it. I grew up on meat. I love meat. I ate a steak. I was a big red meat eater most of my life. I used to work out at the gym all the time, and it was protein. So I ate those meats. Knowing differently now, we were given the information. Even our federal government has changed our food guidelines. So we're becoming more educated now. We need to go with that transition if you want to have a healthier life and feel better about yourself. So it's up to every single individual that's in this group.
I would also encourage, if you are aiming to make a large change in your life, take some small baby steps. Take it one meal at a time. If you've never done whole food plant-based, try out one meal, and then one day you could do like a meatless Monday, for example, and then slowly make it a long-term goal. That's something that you can work towards. A lot of these significant changes don't happen overnight. So if it is something that you feel like interests you and you could see the benefits in it, sit down with yourself and plan out a long-term goal. And I find writing things really helps me or keep myself accountable as well. So maybe write it down, stick it on your fridge, somewhere that you walk by all the time, and reach out to others to help support you, whether it's friends, family, or if you need some support from us in the clinic, we can provide that as well. But yeah, so as long as we're all making small changes towards that, I think that is important too.
If anybody can feel free to contact me, because I've been doing it over the last few years. And who encouraged me was a vegan friend of mine. And vegan has a stereotype that I grew up with. Oh, vegan is, sort of, that's a certain way of life. And they were unhealthy, etc., until I understood more about that particular diet. So, and I ended up getting my support through a particular vegan friend of mine. And I feel terrific these days. And anybody needs any extra help, and I understand. Sometimes you're just going to want to grab that piece of cheese or grab, something as a cheat sheet, and that's okay too, just as long as your main diet is something a little bit healthier. And as you're eating these whole food plant-based meals, gut wise that you're feeling better by eating that. So
Okay, so I think I think everybody has to go where their hearts choose to go, and to me, what I've learned is community. Most of us need a lot of help. For me to be successful, I need a whole community, and we're working together on this. So priority number one for most of us: eat less. Eat less calories. Number two, pick foods that you can eat that are healthy long term. And as the Rachels point out, pick foods that are healthier and take away foods that are less healthy. And let's move forward. Wonderful. What's next?
Okay.
So some specific foods of controversy. Let's start with eggs. So eggs, in case people haven't heard, are really high in cholesterol. Dr. Kearney, what's your stance on eggs?
So I'm an egg white eater. Egg yolks have about 200 to 300 milligrams of cholesterol. And some of us hyperabsorb cholesterol and some of us don't. But the largest, what we call meta-analysis to totally information on eggs is that highest egg consumption is higher associated with cardiovascular mortality. So my recommendation is I eat about three to four eggs a week. I eat a lot of egg whites. So eggs aren't as bad as they used to be. It's I don't fry them in butter. I don't use that four-letter word butter. And so to me is that three eggs, four eggs a week is the most you should be eating. What do you think, Rachel?
Which Rachel?
Both Rachels.
What do you think, Rachel?
Personally, I think it depends on what your current risk is. For me, last time I tested cholesterol, I have a pretty low cholesterol. So I feel like I could eat more than 3 or 4 eggs a week. And I usually do because I really love eggs. But for someone who already has high cholesterol, who maybe doesn't have the best diet right now, eggs could be something that you can limit yourself as of now until maybe you lower your risk, and then you can try adding eggs back if you'd like.
Yeah, I agree. And I also think it's important to compare to what the other alternative would be. So if you're choosing between beans or eggs, go with the beans. If you're choosing between eggs or a fast food breakfast sandwich, I would probably say go with the eggs. Okay, so fish. Fish isn't plant-based, obviously, but it's kind of known as a health food, and I think recent evidence has been shown that those omega-3 fatty acids, specifically one type called EPA that Dr. Kearney has been a pretty big fan of recently, has actually been pretty protective. What's your stance on fish, Dr. Kearney?
So I would like you to cook fish for me on a regular basis because you can actually. So you taught me that the richest source of EPA comes from, I think, farmed salmon from the Atlantic Ocean. Now, in the Atlantic Ocean, there's contaminants, and right now is that we're going to have more plastic bottles in the ocean than fish soon. So most of the fish we're going to be eating will have plastic in it. But saying that, I think is fish can be part of a healthy diet. And one of the things is that I become more of a plant-based eater. Number one for the animals. I don't want to kill things. Number two, the environment, and third, for health. Now, I'm still a hypocrite when it comes to fish. I need to change that. So I don't eat beef or chicken, but I still eat salmon. So I'm saying is that I'm eating salmon for my own health over the health of fish. I have to change that. So that's something I'm not proud of at this stage. But saying that is that fish can be part of a healthy diet if you cook it properly. But like everything in nutrition research, because it's hard to do good quality research with food, because in a proper randomized controlled trial that Paul helped us decide is that the experiment is that a computer decides what you eat and you make one intervention. Food, it's a composition of diet, so it's hard to say. So you always see controversy, and also with the Rachel's point out too as well, there's individual variations. So most of us don't absorb cholesterol very well in our diet, so you can eat more eggs. But some of us are hyperabsorbers of cholesterol, so you have to actually measure yourself. Chad, you're one of the exceptions where you responded well to plant-based eating. There has been randomized data compared to a heart and stroke diet with without plant-based eating, and overall the difference for the average person isn't as great as your response. You're a hyper responder, and that's wonderful, and some of us are. And so I think is we want to try different things. So it's a fair thing to say right now. So to me is that fish is on the healthier side of food, but to be honest, beans are much healthier than fish. So I'm trying to eat a lot more beans and lentils than I am about fish at this point in time. And I think at some point in time I will be not eating fish, and I'm hoping one day there will be synthetic EPA available at 4,000 milligrams at an affordable price, because 4,000 milligrams of pure EPA, which you cannot buy in a health food store, lowers risk of cardiovascular events by 25%. Clear, concise. Good data to support that. Our current preparations of pure EPA that's available by prescription is wonderful, but it costs $300 a month.
Okay, thank you. Next up, we have red meat. So red meat, I think, is right now evidence is pretty clear that it's probably a little bit more harmful, especially for those who are at higher risk of heart disease. There is an underlying mechanism that we're kind of thinking is what's linking the two. So eating red meat increases levels of a gut metabolite called TMAO, and that's been directly linked to atherosclerotic plaque buildup. So if you're choosing between the meats, stay away from the red meat. White meat better than red meat, fish better than white meat, beans better than the fish. Okay, olive oil. So olive oil, a lot of people think it is unhealthy. They think if you just take a spoonful of olive oil a day, it'll keep you healthy. My parents are kind of still on that trend. There is evidence for some of the health benefits of olive oil. There was a trial called Predimed where they looked at olive oil and nuts, and it did decrease risk of cardiovascular disease, I believe. But our current stance is in North America, most people are overweight. Olive oil is a liquid calorie. It's pretty much 120 calories per tablespoon. And you can probably just do it without it. If you're, skinny like Paul and Rachel, maybe you can drizzle that on your salad. But for the majority of us in North America, that level of protection probably isn't worth the trade-off that you get from increased calories. And alcohol, sorry, Dr. Kearney, go ahead.
I think your point's well taken. If you're a skinny individual, then olive oil or nuts has been shown in the Predimed trial to decrease heart attacks compared to a standard heart and stroke low-fat diet. But for most of us, it's too many calories. And that's the problem. I think the number one priority is calories, then composition of diet. So I think the way you summarize it is wonderful, Rachel. Thank you.
Last up, we have alcohol. So alcohol industry is thriving right now in the quarantine. Not as good for the cardiologists out there. Alcohol is not controversial. I think it's been shown that any amount of alcohol is bad. There's been two pretty strong levels of evidence. It's high in calories. Any amount of alcohol increases your risk of cancer, atrial fibrillation, which is a rhythm disease that can increase your risk of stroke, and just overall heart disease. So if like one of the many people who increased their alcohol consumption during quarantine, just consider cutting back down again.
So that's actually important, because at one time we said alcohol is good for the heart. In fact, there's a recent, we call level A evidence, a randomized controlled trial in patients who had intermittent atrial fibrillation. They were recruited and randomized to ask to not drink any alcohol compared to usual patterns of drinking. Now, people didn't stop drinking, but they reduced their alcohol consumption, and recurrence of atrial fibrillation was cut dramatically. Recurrence was 60% if you kept drinking, and was down to about 40% if you actually cut down your alcohol dramatically. So it is a type 1 carcinogen. It says it's not good for pregnant women. So if it's not good for pregnant women, it's not good for overweight guys like myself who are trying to lose weight. And so drink alcohol because you enjoy it. There is no clear health benefit. It is a type 1 carcinogen at this stage. So cyanide's a type 1 carcinogen, so is alcohol. And most people who drink don't think they have a drinking problem. Why in Ontario do we have to keep the alcohol stores open as a priority? Because we have a huge problem with excessive alcohol consumption in many parts of Canada. So I'm not saying you can't enjoy alcohol, but it's not a health food.
Mm-hmm. And I would just re-emphasize what Rachel said before about these specific foods. Always keep in mind what your alternative is. For example, olive oil, even though there are health benefits to olive oil, if you're currently not using olive oil and you're using other plant-based oils and you have a little trouble with weight, it's not that beneficial for you. If currently you're eating a lot of butter, a lot of solid fats, then sure, you can try to replace your fats with olive oil to pick basically less of the evil. Same thing with alcohol. Even if we say, oh, the Mediterranean diet, you get to drink a couple of drinks a week, and that's good for cardiovascular health. If you're not drinking alcohol, don't start doing it because the Mediterranean diet has it in there. But if you're drinking like 3 drinks a day right now, it's a good idea to start cutting down to only a couple a week.
So I say 3 to 4 eggs a week. I'm going to say 3 to 4 drinks a week if the way I look at it.
Mike and Melody in the chat said that was true for them. No alcohol and a lot less aphid. That's great to hear, Mike and Melody. Thanks for sharing that. So moving on, we're just going to do a quick overview on cholesterol medications. Next slide. So starting with the statins, many of you probably heard that if you're here at this webinar today. So some of the common ones include Lipitor, Crestor. The generic names are beside that. And then there's also pravastatin, simvastatin, lovastatin. So they're kind of grouped into 2 different categories. There's high intensity and low intensity. The Lipitor and the Crestor are like the high intensity. Their ability to lower your cholesterol is a lot higher than the lower intensity ones. Next slide. How it actually works is, like Rachel mentioned, majority of your cholesterol actually comes from your liver. So your liver is making the LDL cholesterol, and what statins actually do is just interact or inhibit that cholesterol production or the LDL cholesterol production from your liver. And do they actually work? Yes. So for high dose, high intensity statins, you see around a 50% reduction of LDL. And then if you're at a moderate dose, high intensity statin, around a 30% reduction of LDL. So some frequently asked questions. Maybe Dr. Kearney can talk on this because he probably gets a lot of questions in the clinic about it. So muscle soreness.
What do you think? I'll let you talk first. I'll let you give your thoughts on it.
Rachel, do you have any thoughts on muscle soreness?
Yes. So we actually have a couple of slides on muscle soreness. So here it's a lot of numbers, but we'll walk you through it. Muscle soreness with statins is what we call a nocebo effect, where we don't really believe that it's as prevalent, so as common as we see at the clinic. In the randomized controlled trials where they had a statin versus a placebo that ran for longer than 2 years in duration, I've picked out 3 trials here with a lot of patients in each trial. So for the first one, it's called Heart Protection Study. And the statin they used was a low-intensity statin. It's a simvastatin, 40 milligrams. And there were over 10,000 patients in each arm. So there's more than 10,000 patients on the statin, more than 10,000 patients on the placebo. And a lot of them had muscle pains on statin and on placebo. As you can see from the table here, approximately the same percentage of patients had muscle pains, regardless of whether they're on the statin or on the placebo. The placebo actually had 1% higher muscle pain incidence than the statin. In the second trial, it's called the Corona trial. The statin that they used is a high-intensity statin, so it's Crestor, 10 milligrams, a low-dose Crestor. And they had around 5,000 patients in total, divided half and half. Again, we can see that muscle pain on statin and muscle pain on placebo has around the same number of patients. So patients felt muscle pain regardless of what medication they're on. And the next trial, called the HOPE-3 trial, placed patients on, again, low-dose Crestor and a placebo. So here we can see that, yes, when you're on a statin, a bit more patients seem to complain of muscle pain, about 1% more patient. But at the same time, around the same number of patients complained of muscle pain while they're on placebo. So out of these 3 trials, we can probably see a trend here where, yes, the incidence or the prevalence of muscle pain when you're placed on a statin can be quite high. It can go up to 30%, but it might not be the statin. And the next slide is going to show you why we think so, why it might not be the statin. But just based on this, we can see, okay, maybe it's not the statin causing your muscle pain. Maybe it's something else, your arthritis, your age, your weight, any trauma, your exercise, workouts. All different things can cause muscle pains. So when patients come into the office saying to Dr. Curnew, "Doctor, I have muscle pains, I have cramps on statins, I want to stop my statin," we really want you to think through what your decision is, because as Dr. Curnew said, an effective statin regimen will help halve your risk of a heart attack or stroke. That's by 50 to 60%. And based on what we see here, there's only a small chance of the statin causing any muscle symptoms. And we really want our patients to weigh the pros and cons of a statin medication versus not being on statins very carefully, very responsibly, and honestly before you talk to us about stopping your statins, because it is a very beneficial drug and it can help save many lives. The next trial I wanted to introduce is called the GOS trial. So this is a trial that actually wasn't hoping to investigate statins at all, but there was a phase A of the trial where they put all the patients on a crossover design, where they took patients who have a history of statin intolerance. So these are the patients that stopped their statins because they said, "I had muscle pain."
On 2 different statins. So people complain vigorously, "Dr. Curnew, you are making me sick. You gave me Crestor, you gave me Lipitor, at least 2 medications that were killing me. You're killing me, Dr. Curnew, with my cholesterol pills on 2 occasions." Those are the people in the trial.
Yeah, so these patients are pretty sure, at least themselves, that they have muscle pain on statins. So we took these patients, we re-challenged them with atorvastatin, 20 milligrams, so that's a moderate dose of Lipitor, or a placebo for 10 weeks. They don't know what medication they're on, so they don't know if they're on statin or on placebo. And then we stopped the medication for 2 weeks just to wash the drug out of their system, and we switched them. So if the patient was on an atorvastatin in the first cycle, they're switched to placebo, but they don't know that. And if the patient was on a sugar pill for the first 10 weeks, they're switched to an actual statin for the next 10 weeks. But they have no idea what medication they're taking. And the researchers asked the patients throughout the phase A experiment, "Let me know if you have symptoms with your statins. Let me know if you have muscle pain." And when the results came out, 43% of patients actually had true statin intolerance. So this means that they only complained of muscle pain when they're on a statin. And that's 43% of patients who have told Dr. Curnew on 2 separate medications, "You're causing me pain." Around 27%, more than a quarter of patients, were only painful on placebos and not on statins. And around 10% of patients are painful no matter what you give them. So these are probably just patients who are prone to having muscle pains. We can see here that even though up to 30% of patients can tell the doctor, "Oh, I have muscle pain on statins," only about 43 of these patients actually have statin-induced muscle pain. That's along with that other 30% that also complains of muscle pain on placebo. So forgive us if we try to ask you more questions when you tell us you have muscle pain on statins and you want to stop your statins, because we really, really want to make sure that you're receiving life-saving treatment and not stopping this medication just because you think that you're having a negative side effect. Do you have anything to add, Dr. Curnew?
So by chance, you'll get a 25% to be any box. And so you can see that statin intolerance is a real entity, but the vast majority is probably life. I say if you wake up and you don't have any aches and pains, you're in heaven, or you're on drugs many times. I have an ache and pain every day of my life. I get it. So our goal right now is to find out for sure. And the way to find out for sure is to do something called randomized controlled trials. Look, I have a mask again today. Should I wear a mask or should I not wear a mask? When we first started with COVID-19, the answer was no. The answer is yes. The problem with mask research, it's based on observational data, limited information. So we need to randomize. And what I propose to everybody who thinks that they're still on a statin, and we haven't got this done yet, is that I want to give everybody 4 boxes, 2 real pills and 2 fake pills. And let's find out for sure, because I don't want to make you sick, but I don't want you to die before your time is as well. I still want you to do all the lifestyle changes. The best way to prevent aging is to be fit and exercise and keep your brain working. So again, we're starting the bike ride at 5:30 tomorrow morning, sunrise at my place. Everybody's welcome. We'll go again on Sunday. And yes, Chad, I'm going to eat as many plants as I possibly can. I still a nighttime eater, but we have to find out for sure. And the vast majority of people, keep your minds open to new things. I never thought I'd be a bean eater at this stage in life, and I'm really enjoying it. So I think that's wonderful information. Remember, science is science, and try to use the best science to do what's right for you.
So another topic here we have is on liver damage. So Rachel, what do you have to say about that?
So on liver damage, I've had some patients talk to me about, is Lipitor better than Crestor? Is Crestor better than Lipitor? They've heard that one of the two causes more liver damage than the other. And I just wanted to address that with this table here. I'm right now in this table just comparing the highest doses of both medications, Lipitor and Crestor. So the highest dose for Crestor is 40 milligrams. The highest dose for Lipitor is 80 milligrams. And they do have their differences. So there's one thing that for liver damage, we look at metabolism, because the liver is a very important organ to process your drugs in your body, both for changing them into active forms as well as eliminating them from your body. So the difference between Lipitor and Crestor is that Crestor doesn't actually interact with the liver that much. It doesn't need to be metabolized by the liver, and it's mostly eliminated from your body unchanged from when it got in. However, atorvastatin, Lipitor, is processed by the liver, and that might be why some people have the belief, well, why atorvastatin actually does have a little bit more liver enzyme elevations compared to Crestor, because it actually needs to get past the liver, get processed by it in order to reach its active form. In terms of the actual liver enzyme elevation, the ALT elevation is what we look at on your blood test. Crestor does have marginally better numbers than Lipitor. They're both very low, ranging from 0.5 to 2%, a little bit. And yes, Lipitor can raise your liver enzymes a bit more than Crestor, but it's important to remember that increased liver enzymes does not mean that you have a serious liver injury. A lot of medications can increase your liver enzymes. What's important is that there is a certain limit that we look at, and actual liver injury is not common at all with any of the high intensity statins. Some of the other differences is basically Crestor is actually a bit better at lowering your lousy cholesterol by Lipitor. It lowers your lousy cholesterol by 56%, Lipitor by 51%. It's marginally different, but if you like to play with numbers, maybe you want to choose Crestor. It also has a bit of an edge with COVID-19 right now. Dr. Kearney might want to talk about that later. But generally, they're the same. In terms of renal excretion, Crestor goes through the kidney more than Lipitor. So if someone has renal failure, kidney failure, or kidney disease, then they should be on Lipitor because Lipitor puts less of a stress on the kidneys, as it doesn't need to go through the kidneys to get out of your body as much. So those are basically the differences. Clinically, they don't make that much of a difference. And yeah, clinically they don't make that much of a difference. The side effects of liver injury, of severe muscle damage is very low, regardless of whether you're on Lipitor or on Crestor. But if you are extremely worried and you want to look at the numbers in great detail, and you're worried about liver injury or liver enzyme elevation, then sure, you can choose Lipitor over Crestor. I'm sure Dr. Kearney will be happy with both.
They're both phenomenally great drugs. One is more water soluble, one's more lipid soluble. It means it penetrates the brain differently, penetrates the muscles differently. So it's good to have choices. As we started off the webinar, is different strokes for different folks. These are both first-round draft picks. They're both phenomenally good drugs. I take both of them interchangeably. So I think those are some of the differences. Thank you for sharing those differences. And again, we can monitor. We can look at the liver. We can look at your muscles. We can see if there's liver damage. We can see if there's muscle damage. So that's why we do blood tests. And but they're very safe drugs. And as you point out, just because your liver tests are abnormal doesn't mean you have liver damage. So that's actually important too as well. But we have ways to watch for this. Thank you.
All right, so another cholesterol-lowering medication that we have is Easytrol. I think we kind of refer to this as like I don't know the hockey terms, Dr. Kearney, but like the side player that helps out the star player or something along those lines. So
So Wayne Gretzky is Lipitor Crestor. Is that why it is Martin McSorley or a third-round draft pick? And Rachel explained why that's the case.
Yeah, that reference just went over my head. But anyways, so Easytrol completely bypasses the liver. So if you're worried about adding another medication on top of the statin and like causing more effects, then don't need to worry about that. Like Rachel mentioned at the very start, cholesterol comes from your liver and your small intestine mainly. So what Easytrol does is it blocks the LDL cholesterol absorption from your small intestine into your bloodstream. And in terms of if it's effective or not, the reason why it's not a first round draft pick is because, click next, reach. It only reduces your LDL cholesterol by around 15%, maybe 20%. So it's a really great add-on therapy onto a statin if you're still not on target with a statin, or for some reason you want to take half a dose of a statin and add something else that doesn't go through your liver. But probably not the primary medication that you want to be on if you have a high cholesterol to begin with. And then a question that we have a lot is, oh, I tried the statins, side effects, got the Easytrol side effects, worried about this, muscle soreness, liver damage, all that. There's a medication called PCSK9 inhibitors that's been I don't know, gaining some traction recently. So how this one works is, so the liver, there's LDL receptors that binds the LDL cholesterol and metabolizes it. And then there's another component called PCSK9 that binds to those receptors and then causes the LDL receptor to be metabolized. And that's bad because it means it reduces your body's clearance of LDL. But then with the PCSK9 inhibitors too, it's an injectable. It blocks that PCSK9 compound and promotes, or it keeps your liver being able to like clear the LDL. So yes, they do work really, really well. It's actually a similar effectiveness to the Lipitor and Crestor in lowering LDL cholesterol, which are the first round draft picks. But like everything in life, there is a big caveat, and it is that it is very, very, very expensive. We're talking several thousands of dollars per year. And getting coverage for that is pretty difficult, I would say. So not an option for everyone unless you have just $7,000 a year to spare. Maybe Dr. Kearney can talk a little bit more about PCSK9 inhibitors and who he might recommend them to and not.
I love these drugs. They're phenomenal drugs. They're just unaffordable. I wish Quiet Leonard stayed with Toronto Raptors, but the Toronto Raptors are a phenomenally good team without him. So you can have phenomenally good cholesterol without being on a PCSK9 drug. I'm not saying you shouldn't be on it, but they're they're expensive. There are new drugs that are coming out that may be by injections every 6 months, but that's still in the pipeline right now. So we learned a lot. And this, what these drugs have taught me, is that the lower LDL cholesterol. So this has been shown on top of statin therapy, PCSK9 drugs, you can lower your cholesterol less than 1 in many patients. And so for some people, that's the right choice, but it's not for everyone. So we make choices. It's good to have choices. So I love these drugs. Just the price limits how we're going to use them.
Okay, we've come to our key takeaway slides. So these are the messages you should take away from this 1.5 hour talking. One is that high cholesterol damages your blood vessels, and you don't want them in your blood because they can lead to heart disease. And 2, L stands for lousy, H stands for healthy. Remember that. And you want the lousy to be low, you want the healthy to be high. When it comes to diet, try using the plate method, filling your half of your plate with veggies, minimize the trans fats, minimize the alcohol, be aware of what your alternatives are. Don't just jump on olive oil boat because you've heard that it's good for you. Be aware of your circumstances and your alternatives. It is difficult to lower your cholesterol with just lifestyle changes, with just diet. But if you can maintain or achieve a significant lifestyle change, then for sure you can make some, do some changes in your cholesterol. But for most of the population, it's very hard to do so. And that's why there's cholesterol lowering medications, which are very safe and effective in lowering your cholesterol.
Yeah, it can be really challenging to make a drastic lifestyle change that's gonna really improve your cholesterol levels and overall health. So thanks to everyone for coming to this group. We all need to constantly adapt and keep each other accountable. On the right to the text, these are some images from Dr. Kearney's website. It's actually from a 30-day health challenge that we did over a year ago, where we challenged patients and volunteers to go completely vegetarian for 30 days straight. Those were the only 30 days in my whole entire life that I actually went completely vegetarian, but I was able to do it with the support of everyone. And we posted pictures and recipes online. And it just, as I was just like sifting through the website, I came across this and it reminded me of how just having the support of everyone and seeing that online presence and seeing everyone else kind of struggling along with me helped me to make a drastic change for that one time in my life. So thanks everyone for coming.
So to me, this really summarizes a lot, is that the foundation to good health is lifestyle changes. We forgot that. You know, look at our young people. They're skinny, they exercise, they run around. Look at many old people, we burp and watch TV, and we complain. So Chad, you're right, we have some choices. So, and we're trying to make that feasible and possible. That's why we keep learning and getting better. I'm not the same person. I still have a lot more to learn. The science has taught me a lot, and science is science, and you'll always hear disagreement. But saying that is that we made a huge difference, and people like the Rachels, Paul, and everybody else. There's hundreds of you out there that have changed the world, and you will change the world more. Chad, you're changing the world too as well, and we're getting there. And to me, is if you can do it by yourself, terrific. I think 99% of us or 90% of us we need other people to help us as part of the team. And part of the team is to be in contact. So this is why these webinars are so important. That's why Paul has put them together so masterfully. He records them. They're there for everybody to use. What I want is that if you have any questions or you need some help, you can always email us at drkernew@232gmail.com what you need. So he said, listen, I want to change some of my eating habits. I want to understand about diet. I want to understand about exercise. I want to stop smoking. I'm depressed. I'm sad. I get it, but I want people to work at this, and we'll help. And that's one way of getting a hold of us. What I promise is I'll never be on time, but if you have a problem, I'll find a way to fit you in. And I really say that. But what gets me scared and nervous is not trying. And I don't mind. My biggest hero right now is Elon Musk. He blew 3 rockets. He spent hundreds of millions of dollars, and people told him he was crazy. Yeah, he's crazy. He's a good crazy. He's changing the world, and we can all change our little part of the world too as well. I'm very much into listening to TED Talks. So in TED Talks there's lots of experts on there giving advice. And one of the things is that I learned from this young lady, I forget her name, is that she's an expert PhD on why do people achieve greatness and achieve the top of what they're doing. And basically the number one predictor of achieving greatness and success is hard work and not being afraid to fail and trying again. And so I learned a lot. This is a wonderful presentation. I want to thank Rachel for their years of support. When they actually finish medical school, I hope they'll take me on as a patient or actually take over my office, or I'll work for you. Chad, we're going to still be there, oil-free cooking, and we're going to get the world to be a better place. Paul, you're going to change the world, and everybody else is going to change the world, and we're working hard on this. Questions or comments from anybody? Was anything in the chat box there, Paul? Paul, you have some fun.
Chad has been leaving some very thoughtful comments throughout the entire discussion. If you've been watching on YouTube, you can see little pop-ups of Chad's comments as well. In the box here on WebEx, for those of you joining us, I have linked this form that the Rachels have created. And those that are watching on YouTube, you can also find the form just on the right for that chat box. So I do recommend you go through it, fill out the form. One thing that I noticed Chad was very regularly mentioning throughout this entire time, he does emphasize that, it's as a patient, he believes that's really important to find some support. Find people who can help you out, whether it's friends, family, or anyone at this clinic as well. And it is important to take some steps into your own health. So I do really thank you, Chad, for sharing these very wise words. Everyone who's watching can see all the comments that you left as well, and I'm sure it's going to have a great impact on them. So I guess final words, I do want to thank both the Rachels once more for coming out. I think this was one of my favorite presentations that I've seen. It was just very clear and concise, very key takeaways that I think everyone should know. It's very important, or cholesterol, as we've learned, is very important for your health and will have a drastic impact on your cardiovascular health moving or throughout your entire lifespan, actually. So we saw a patient as young as 4 years old, and a lot of us here are definitely a lot older than 4 years old. So it's something that we should consider. So I think, Dr. Kearney, do you have some closing thoughts?
Just get healthier, keep working at it. And if you don't succeed, try again. Don't be afraid to fail. Just enjoy the process and keep learning. We decided we're talking about next week, Paul?
Next week, I believe we were talking about lung disease.
So I have some updates on that. I was speaking to some more experts about that. So we got lots to talk about. Lung disease, we have triglycerides, the nursing home situation, atrial fibrillation. We have about 10 other topics we're working on. Fantastic. So remember, all these are recorded. I guess I want a special thanks for all of you for being here tonight. Some of us are going to stay on the line just to chat a little bit. Everybody's welcome to. For those, eat well, be healthy. Special thanks to both the Rachels. You both have a very special place in this clinic in our hearts. You've helped so many people already. You're going to help a lot more as time goes on. So thank you. Have a good night, everybody. And let's say a warm applause for a wonderful presentation. Thank you so much.